Yeah. Good evening, all of you.
Good evening.
I invite you all to this webcast on drug-induced liver injury. This will be a panel discussion. I will be the chief moderator. Along with me, Dr. Akash Shukla, Dr. Joy Varghese, Dr. Girinath, and Dr. Thomas will be leading the discussions. I am at Regency Super Specialty, Lucknow, and I am an intensivist, probably the odd one out. Dr. Akash Shukla is a noted physician and gastroenterologist in Mumbai. He's associated with GS KEM Hospital, and he's also associated with Global Hospitals in Mumbai since 2012 as transplant hepatologist. He has several articles in various journals of repute, and he has been an invited faculty at many conferences. Dr. Joy Varghese joins us from Chennai, Perumbakam. He's the Director of Hepatology and Transplant Hepatology at Global Hospital in Health City, Chennai. He has also worked as visiting consultant in renowned hospitals like MMC and Kumaran Hospitals in Chennai. He received a medal in MD by Association of Physicians of India. He has been honored with British Young Investigation Award. Dr. Girinath joins us from Vizag. He is Associate Professor and in charge HOD Department of Gastroenterology, Andhra Medical College, King George Hospital, and his special field of interest is advanced endoscopy, ERCP, cholangioscopy, balloon-assisted endoscopy, and luminal metal stents. Dr. Prasanna Kumar, sir, is a chest physician from Chennai, and he is a very active social worker. His social commitment for betterment of economically weak section is known well in his circles, and he has chapters in various textbooks and on pneumonia. He is attached to Fortis Malar Hospital, Apollo Clinic, and Jeevan Dhanam Clinic. We'll start with the panel discussion on drug-induced liver injury. The first question is to Dr. Shukla. What is drug-induced liver injury?
Hello, everybody. Thank you for having me here. It's indeed a pleasure to share this platform in these tough times. Drug-induced liver injury is nothing but when a drug has an adverse event on the liver. Now, it could be something as mild as just mild elevation of transaminases or slight elevation of unconjugated bilirubin, something like atazanavir does, or it could be just mild increase in gamma GT or alkaline phosphatase, or it could be as severe as acute hepatitis, acute liver failure, chronic hepatitis, chronic liver disease, cirrhosis, decompensation, and even fatality. So all these constitute the basic spectrum of drugs causing liver injury. And many of these drugs do not cause it routinely. So there could be idiosyncratic, in susceptible individuals where there's abnormal reaction to a particular drug. And in some cases, it is a predictable thing which happens infrequently, which is dose dependent. And that too happens in a staggered manner. And again, it usually would happen in people who are predisposed, either metabolically, genetically, or because of their other vices like alcohol.
So, as rightly pointed out by Dr. Shukla, drug-induced liver injury is caused by medications. It could be prescription medications or over-the-counter products, herbal and dietary supplements. This again becomes a big etiological entity for DILI, or other xenobiotics that results in abnormalities in liver tests or in hepatic dysfunction that cannot be explained by other causes. There are essentially two types of DILI. We'll see in detail what are those two types. Dr. Girinath, what is the magnitude of DILI? What is the epidemiology of DILI, especially in Indian subcontinent?
Yeah. Throughout the world, the incidence of DILI is around 15 per 1 lakh population in various studies from Iceland, French, and Spanish studies. But from India, there is a recent publication in 2017 by Dr. Prabha Sawant from Mumbai, which showed around 13 per 1 lakh population is the incidence of Delhi. But remember that people use a lot of over the prescription drugs, herbal medications, which are not accounted for. So we don't have a proper denominator to see what exactly people are taking, and lot of asymptomatic injuries will be there. So to account for all these things, we need a proper retrospective studies. And recently, the United States has proposed an ongoing study from the last 10 years. I think after 3-4 years, we'll have the good data about the incidence of the delay. But right now, from India, it's around 13 per 1 lakh population. And going by that, when we see the class of drugs as such, when compared from the West and East, in the East, it's mostly the anti-tuberculosis drugs, followed by herbal medications, and then the retroviral drugs. And in the West, it is more to do with acetaminophen and then NSAIDs. They form a chunk of the list of the cause of drugs. These are the most common drugs. And when it comes to acute liver failure, again, in the East, it is more due to, again, ATT. It's almost 50% to 60% is due to ATT, induced, drug-induced liver. And in the West, it's again 50 to 60% is due to acetaminophen.
Yes.
So the prescription manner in which it is written, and it differs. So this is the in short about the epidemiology throughout the world and in India. So probably I think we are still in this ATT-based induced hepatitis. We see more of ATT-based induced hepatitis. And of late, we are seeing more commonly these antiretroviral drugs, and then some cases of dapsone-induced hepatitis. But till now, I think this is the data which we have. And over to you, Dr. Javeri.
Yeah. Dr. Girinath, I'll stay with you on this question. We only see vast majority of inpatients with Delhi, and we are missing a huge proportion of outpatients. Like, I am not remembering the drug. My father-in-law was started long back, about 5-6 years back, on an antihypertensive, one by a general physician whose side effect was hepatotoxicity. And by chance, he never told, and we were also out of the city, so we never realized, and we came to know after 6 months when we did a liver function. So it's quite prevalent, and probably what we see is again a tip of the iceberg. What do you say?
Almost 90% actually we miss the asymptomatic liver injuries. So that's a big problem with this problem. And the idiosyncratic drug injuries can occur even after you stop the drug. It can occur within 1 year also. So this is a big problem with this idiosyncratic type of reactions when we come to delay.
The true prevalence of delay is hard to ascertain, especially in our part of the world. One reason is pre-marketing clinical trials are underpowered to detect the presence of idiosyncratic delay. US, the annual incidence is 10 to 15 per 10,000 to 100,000 persons exposed to prescription medication. Therefore, about 44,000 people in the US will experience delay annually, making it costly in terms of not only its toll on the humans, but also on other healthcare expenditures. The prevalence is expected to increase with widespread use of herbal and dietary supplements. And the scenario has changed widely in India also. Last 8 to 10 years, 12 years, we are seeing more and more of people who are coming with use, or shall I call it abuse, of these herbal and dietary supplements. Of the 2,000 cases of ALF that occurs in US each year, medications account for more than 50%, with about 37% of cases attributable to paracetamol and 13% attributable to idiosyncratic adverse drug reactions. Dr. Girinath, you wanted to say something?
Yeah, that's the same thing. The incidence throughout the world is same, but only the type of drug, the class of drugs vary.
You explained it very nicely. I'll go on to Dr. Thomas, sir. How common is delay in your practice, especially you are writing ATT also? Apart from your pulmonary practice, how often do you see in other specialties, like in critical care or in outpatient general practice? Is it underrated do we miss that diagnosis?
Thank you, sir. I think it's a great pleasure to be here. Thanks, Juventus, for having us on this panel. And I feel like Alice in Wonderland as I sit here, drowned by the gastroenterologist. And I think I hope I'll get my head up here. My take towards drug-induced liver disease, I think, will be basically not from the inside but from the outside. I'm looking at it purely from the point of view of my patient tolerating whatever drugs that I'm giving him. And if I think that these drugs are related indeed to liver disease, then I look at it that way. If you take the regular antituberculous drugs for that matter, and you will find that it's not surprising that because there are a lot of these fixed dose combinations, we often push the dose in these patients without relevance to weight, and we find that they come back to us with problems. The advantage with me is that I quickly detect them. Very rarely do I need to really have a space where I miss this, because they're just not able to tolerate the drugs and they will come back to me. That I think is my biggest advantage. In 10 days, I will know whether he's got a good drug tolerance or not, number one. Number two, in 10 days, I'll know whether his liver is tolerating the drug, whether his GI is tolerating the drug. Within a very short time, I think I will be able to make that out. I really don't need to look at post transcripts over a period of time, because 90% of people who accept antituberculous drugs comfortably over the first 30 days will continue to accept it over a period of time. That's one. The second is, as far as the other drugs are concerned, especially drugs for asthma and COPD, there's really no problem at all. There are drugs for interstitial lung disease like pirfenidone for that matter, which need to be monitored as far as liver function is concerned. Drugs for pulmonary hypertension sometimes need to be monitored for liver function. But even there are being exceptions today, drugs like ambrisentan for that matter, that you don't need to check your liver enzymes. And pirfenidone, for example, you need to check. Nintedanib, for example, you don't need to check your liver enzymes at all and you can go. So we are probably moving to something else. And as far as the specific antituberculous drugs are concerned, I think we will keep it for the next stage of questioning. Thank you.
Thank you. Shall we take this as a dictum? New onset organ dysfunction in an otherwise healthy patient. We should always check the medications as the cause?
Yes, I would. But the point really is that what would you check? Would you check investigations or would you check clinically? And I think these three things are three clear verticals that I'm going to give. I have given him the drug. Then what do I check? Do I check his enzymes every time? Do his enzymes every 15 days? Of course, his enzymes will go up with all the rifampicin and the iron that he's having. We know that the enzymes will go up, plateau down for some time and come back after about 2 to 3 weeks. I won't be too worried about it. In fact, I won't be worried about it to the sense that I won't even keep doing a liver function test at all. Yeah. I'd rather look at his symptoms, and 95% of patients will be comfortable. And once we know that they have no symptoms, we almost certainly think that there is no liver injury as such. And only when he comes back with symptoms, then we try to see what we need to investigate as far as the liver is concerned. So the question of doing routine isoenzymes for that matter in patients who are prescribed antituberculous drugs, I think is a sort of misunderstood concept that we need to take a look at very seriously. And I think if it's done very frequently, probably checking for the liver function test will cost more than the antituberculous drugs themselves.
Dr. Girinath, I'll come to you on this. You have a patient referred to your OPD by another colleague physician who has new onset liver dysfunction. How will you proceed? Why I'm asking this question again and again is, see, practices vary from country to country and region to region. And this part of the country, we see a lot of quackeries, untrained people, and some physicians also practicing loosely. They just don't tell the patients, they don't educate their patients about the side effect. That is why I'm stressing on this question again and again.
Yeah, usually in my OPD, I always make it a point to take a proper history, because we always miss the history. Because sometimes the patients take it lightly that we have used a drug 1 month ago, 2 months ago, it's okay. For some muscle building activity or some other disease, which they are also not sure of sometimes.
Yeah.
So, especially patients when they come to us with deranged liver, and then you don't have all the common viral marks are normal, and you're still not able to know the cause of the disease, definitely you have to put a mind across the drugs. So definitely, in my practice, I've seen a lot of cases, like in our area, apart from tuberculosis, a lot of people use this dapsone for skin manifestations.
Yes.
They are not aware. They take the drug continuously, even after developed jaundice also, they keep on taking dapsone sometimes. And sometimes there is a multiplicity of drugs, like they are on anticonvulsants, suddenly they take some other antibiotic. So this history is sometimes not given. So they take it 2 weeks ago, and then they come to us. After 2 weeks, they have mild fever, little derangement of liver enzymes. So this is a stage actually. If your diagnosis is not fitting into a proper viral syndrome, you have to be very careful in eliciting a long 2 weeks history of fever, mild derangement of enzymes. Patient is mildly sick, not very sick, but still we have to be very careful in asking the history. So this is very important. And also in my practice, what I have seen is in our areas, when people are given ATT, sometimes the underlying, there's a compensated liver disease, which they are not aware of. Once they take this ATT, then they decompensate. So this is also of concern. So before we prescribe, sometimes it is utmost important that we do rule out a underlying compensated liver disease, chronic liver disease. So this is my take.
Yeah, thank you. Dr. Varghese, do you have the luxury of having a clinical pharmacist in your OPD or at least in your IPD?
In our IPD, there are the clinical pharmacists because all the inpatients, so like after our rounds, routinely the clinical pharmacist will go through the drug chart. If there is a drug interaction, some issues related, they will bring it to our notice. Here, I mean, regarding the Dr. Thomas, I'm slightly disagreeing with his point, sorry to say. Before we get the symptoms due to the drug-induced liver injury, if you are identifying the lab test-wise, the early detection of the DILI, that is mostly helpful in practice, either to withdraw the drugs and we withhold the drugs and we will see and we can easily correct it. The reason, as we are the hepatologist, sometimes we are seeing if the patient comes with a full-blown jaundice, then as Dr. Greenath has pointed out, already they have the underlying liver disease or even the fatty liver. And there are a lot of other factors which is influencing the outcome of the DILI severity. Example, I can say the obese individual, elderly population, and if they have associated diabetes, particularly the female, because we have seen if that particular individual, if they are continuing the drug and they are developing with the full-blown symptoms, then they might require a hospitalization, and even after withholding the drug, the recovery phase is, so instead of that, just we can check the liver function test once in a week or once in 2 weeks, even though not full blown. So first usually it will come as a transaminitis. We can order, suppose the financial part, SGPT and SGOT. Just we can see whether the alkaline phosphatase also, because the DILI will behave is either sometimes based on the drug related, not only I'm talking about the ATT, even though anti-epileptic drug and other drugs, it will either hepatitis related or it will behave as a cholestatic type or sometimes a mixed type. So if the ALT shows more than 3 times of the upper limit of the normal, there is a hepatitis pattern. If the alkaline phosphatase shows more than 2 times of the normal, that is the cholestatic. The mixed type is the both ALT elevation as well as the alkaline phosphatase. If we comes to know that time, we can go through that. We can without either anti-epileptic drug or whatever the drugs. Okay, if you know that the hepatotoxic drug, that will be. It's my opinion.
Yeah, Dr. Thomas, you want to say something on this?
Yeah, exactly. Now basically, I think it's a question of when you start anti-tuberculosis drugs, you decide whether he has a suspicion or you have a suspicion of pre-existing liver disease. If you have a suspicion of pre-existing liver disease, be very cautious with the medication weight-wise. You definitely can check your liver function before you start. But I think an ordinary 23-year-old guy who comes to me who has a pleural effusion, and I'm going to start him on anti-tuberculosis drugs. This guy is running around all over the place, spends 25, 30 minutes in the gym. I don't think it's proper to do to do a liver function. I'm sorry, to do a liver function test for him before I start my anti-tuberculosis drugs. One of the best in-between formulas that you can find is that I generally start for the first 10 days only. And those 10 days are to tell me whether he has better GI tolerance or poor GI tolerance or hepatotoxicity itself. One of these three verticals I will know in 10 days as to whether he's having it at all. And if he's having it in 10 days, I can always draw back and go to the to the liver function test and then see what best I can do. So this 10-day stuff is a very good approach to these things where you detect patient's ability to tolerate medication. The other thing is the medications themselves today. Now there is a change today. We all know that rifampicin, INH, and pyrazinamide are the sort of worst entities as far as the liver is concerned. And we also know that drugs like ethionamide, cycloserine, and prothionamide are extremely GI unfriendly. I don't know if I'd call it GI toxic, but then they are GI unfriendly. So they may not cause direct liver disease. They're extremely GI unfriendly. But I think we are moving from these drugs to drugs like, for example, bedaquiline, delamed, linezolid, um, 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 protonamide, and other drugs, which moxifloxacin, for example. These are much better tolerated drugs. And these drugs, which were reserved for only things like MDR and XDR in the past, are now being tried for naive patients with sputum positive tuberculosis. So you can shorten the duration of therapy to as short as about 26 weeks or 28 weeks or 30 weeks. There are trials like the Bangladesh trial and things like that, for example, which tell you that. So we are shifting from a focus where we think that gastrointestinal tract itself is probably, I won't say a hindrance to anti-tuberculosis drugs, but can become an uncomfortable factor as far as your drugs are concerned. And I think we're shifting towards better drugs in the future. And I think down the line, this question of hepatic and gastrointestinal toxicity to anti-tuberculosis drugs will definitely come down.
Dr. Shukla, I'll come to you on this now. In the inpatient setting, especially in the ICU, often we miss the diagnosis of drug-induced liver injury, often labeled as multi-organ dysfunction or ischemic hepatitis. What is your take on this? Or labeled as sepsis. Everything is sepsis in ICU.
Very true. In fact, I think one of the biggest challenges is to identify the cause of abnormal liver functions in a patient who is acutely ill.
Yes.
In ICU setup, or even in an indoor patient who is on polypharmacy. And when you look at the list of drugs, you will always find that almost all antibiotics have a risk of hepatotoxicity.
Absolutely.
So you have a patient who is on ventilator, who has come to you with pneumonia, ARDS. He is on 2 inotropes. He is on meropenem. He is on 2 other antibiotics, antifungals. It becomes practically impossible to assess whether the abnormal LFT is because of drugs or because of sepsis or because of any other reason. Now, here we have to use our clinical clinical judgment, and we have to look at the patient profile and take individual decisions for the patients. One of the clues here is, for mild elevation of enzymes or for mild elevation of bilirubin, usually up to 3, you can safely ignore, because the drugs are likely to be more beneficial in these setups as compared to the risk of mild elevation of enzymes or just mild elevation of bilirubin. what you are going to be concerned about is, you remember the Hy's law. A drug which causes rise in transaminases significantly is also more likely to affect the outcomes and have higher risk of mortality. So I think the cases where you get very high enzymes, that is where I would be more worried. And this, again, would be very important to differentiate between drug-induced liver injury, where SGOT-PT are more than 300, 400, 500, and ischemic hepatitis. So again, in this group of patients, you would look at their hemodynamic profile. If there's a history of severe hemodynamic instability, or sometimes even mild hemodynamic instability, or if there is a rise in creatinine just along with the rise of the enzymes, then you know that you are dealing with ischemic hypoxic hepatitis rather than drug-induced liver injury. The bigger challenge is if you have somebody who has got progressive bilirubin in the ICU, and the bilirubin goes on to 10, 12, 15, 20, 25. We know that with those high bilirubins, it becomes very challenging to manage this patient, because such high bilirubins by themselves will affect the neutrophil function, it will affect the monocyte function, and will have even renal toxicity. So there, whether the carbapenems have to be blamed, or it is just an unresolved sepsis. So those are the questions which come to our mind. One of the key things here is to ensure that we are not dealing with an unresolved sepsis.
Absolutely.
Very often you'll see the bilirubin going very high in patients with even 10, 15, 17 with unresolved sepsis when the patient is in ICU for 2 weeks, 3 weeks, 4 weeks. The other reason could be TPN.
Absolutely.
And look at the constitution of the TPN, whether the lipids are being given or not. So once you take into account all these things, you arrive at a decision. Unfortunately, there is no simple way to give to differentiate whether this is drug-induced or TPN-induced sepsis, or we don't even know if it's quite often a combination of the three.
Yes.
So you have to individualize, looking at the patient profile, the clinical status of the patient, and then arrive at a decision as to what are we really dealing here with. I'll just quickly add to the point which Dr. Thomas made. As hepatologists, we tend to see the patients who have developed the hepatotoxicity. Dr. Thomas must be seeing a huge number of patients who do not develop the hepatotoxicity. So our view is likely to be slightly biased, and we would almost always err on the side of doing slightly extra tests. What we have to remember here is ATT is just one of the drugs. There are hordes of other drugs where the hepatotoxicity is missed. One classical example I would give is anti-epileptics. Patients are on phenytoin for long periods of time, and nobody bothers to do their TDM levels are done, but not their liver function tests. So I think for drugs which can cause damage over a long period of time, and the symptoms can remain subtle for a very, very long period of time, methotrexate is another example. Leflunomide is another example. So for these conditions, intermittent testing of liver biochemistry, I think, is important. It could be once in 3 months, it could be once in 6 months, but it needs to be done. I think TB is something which I would remain out of debate, because I don't think ever two experts agree on anything on TB. So I'll leave that aside. But I think for all other cases, I would agree with Joy that I think testing is very important for those hepatotoxicities which are subtle, which happen over a long period of time, but can eventually end up with life-threatening complications like cirrhosis.
Yeah. We'll move on to the next question, Dr. Varghese. This question is for you. How big are the problems from non-allopathic drugs like homeopathic, herbal, traditional Chinese medicine, Unani, Siddha, heavy metals, drug supplement? Well, how big is the problem in India?
Just in short, I can quote the recently published paper from Dr. Cyriac Phillips from Kerala. So he has published the data on the herbal, because the Keralite mostly they will used to get this kind of the herbal medicine, Ayurveda medicines, etc. So normally we will know only either it will manifest as a simple jaundice, but that paper he has quoted, it has come as a sinusoidal obstruction syndrome. So mostly the patient is presented with that ascites, pedal edema, and volume overload. So the herbal medicine, so if you look into the mechanism, so like similar to the DILI, drug-induced. So either it will be idiosyncratic. Idiosyncratic means it is not dose dependent. Another thing is it's a intrinsic hepatotoxin, there is a dose dependent. For example, paracetamol poison. So it is a dose, as at one time at 10 grams a day, it's a lethal, it causes IQ, we know very well. The idiosyncratic, again, we can classify into the one is the immunological related and another the non-immunological. The example for the immunological method is the sulfa allergy. If you are taking a medicine, within few minutes or penicillin, we are getting the immunology related, the entire reaction. So others all coming the metabolites. So the idiosyncratic, non-immunological, but the drugs or the toxin, its metabolite is causing the cell injury, the liver injury. So these herbal medicines or Unani, whatever it is, this all, its cause comes into the idiosyncratic, non-immunological, and also the metabolite. Its derived metabolites causing the liver damage. So if you take the Tamil Nadu, so I mean, as you were mentioning Delhi, even though the ratol poison, so this common, that also comes at the dose dependent. So the one end, the dose dependent comes the paracetamol, and even though the heavy dose of all the whichever the hepatotoxic drugs, and if you are taking the overdose, that related, and the ratol, this Unani, homeopathic, Ayurvedic, everything will come in the other category.
Thank you. More than 60% of cases of DILI are attributed to antibiotics and epileptic agents, and we already discussed herbal and dietary supplements are coming up as a big etiological factor. Dr. Girinath will move on to the next part of the discussion. What is the mechanism of injury with DILI, and what are these intrinsic versus idiosyncratic DILI, which we have been talking about? And incidentally, I learned a new word today. IDILI. It reminded me of Italy. So idiosyncratic drug-induced liver injury. Yeah, please.
Yes, Dr. Joy was just discussing about this classification of mechanism, how the injury occurs. But for all the audience sake, just let us just take a substance which goes into the body, a xenobiotic. So basically, it is the liver which detoxifies and then sends it into the biliary system, and then through the urine and feces it comes out. So this is the detoxification, and all the hydrophilic substances through the kidney, right? So now comes the question about the lipophilicity of the xenobiotic. So more lipophilic xenobiotics, they go through the liver. So there is what is known as first pass mechanism, and then the second pass, and then the third level mechanism. So in the first reaction, what happens is everyone knows that there is a cytochrome system in the liver. So this is the basic system which first actually detoxifies a lot of drugs or xenobiotics. So there's the phase 1 step. So almost 50% of the drugs can be detoxified by this first phase 1 step. Then comes the second step, wherein there are some reactive metabolites that are formed, and these need to be conjugated either through sulfa or glutathione or glucuronidation. And again, they get detoxified and then goes into the And then the third level is where, like, you can have a immunological reaction where again these protein addicts actually they induce immunological reaction. That is the state of acute immune response. This can produce what is known as hypersensitivity reaction. Yeah. So this is what is known as acute hypersensitivity reaction, just like as we see in Stevens-Johnson syndrome due to sulfas or something like that, or phenytoin. So basically it is intrinsic cumulative toxicity, and the idiosyncratic. Again, in the idiosyncratic, there are some metabolites which accumulate, and usually our body has an immune system, that is adaptive immune system, which controls and tolerates this, all the reactive metabolites. And some of the proteins, the metabolites can stimulate immunological disease. So little into the mechanism, basically what happens is once there is heavy load on the liver, which is surpassing the cytochrome system, then this can bypass and produce some action on the mitochondria, thus producing some reactive oxygen species. This again induces a lot of oxidants, which the liver cannot take by the normal mechanism. So this stage happens, and again there is a formation of other oxidants which can cause necrosis through the MAP kinases or JNK system, which produces a lot of cell necrosis. This is the routine hepatocellular necrosis that happens through the intrinsic pathway. When it comes to idiosyncratic, what happens is, we know that there are some developments of protein adducts known as haptens. This can either be tolerated because depending upon our innate immune system, or this can be stimulating a immunological reaction, just like the hypersensitivity reaction. So these are the basic mechanism by which the liver can get damaged. One is hepatocellular damage through cumulative toxicity and then hepatocellular damage, or these protein adducts forming immunological stimulation, and then lot of cytokines release, again mitochondria damage, lot of oxidants released into the body, and again causing lot of damage. So this is the basic which we think as hepatocellular damage and idiosyncratic. There are other actually mechanisms wherein there is damage directly to the mitochondria producing microvascular steatosis, like we see the microvascular steatosis because of methotrexate, all those drugs. And then we have some other drugs producing only tumor-like regenerative nodules. And then we have some anabolic steroids which produce, so their mechanism is different. But the only good thing is that this, whatever it is there, the hepatocellular jaundice, this is more lethal. The other types of mechanisms, they don't produce so much of damage and fatality. That's the problem. So I think these are the basic mechanisms.
Yeah. Dr. Shukla, what are the common medicines which you encounter in your practice are causing delay?
So I think the commonest antibiotics which we face hepatotoxicity, one is coamoxiclav in OPD practice. I think that is something which is underreported and understated, especially because you see the hepatotoxicity around 3 weeks after the start of drugs. So by the time most patients come, they would have forgotten that they had taken coamoxiclav. So because usually the course is 5 to 7 days. My first encounter was when I was doing my MD residency, and we had a student nurse who came with acute liver failure because of coamoxiclav. We very often will see mild elevation of enzymes in patients who are on NSAIDs. So I think that is another group of drugs which people fail to investigate. So very often patients don't even consider them as drugs. So when you ask whether they're taking any medications, they would very often not even remember that they are on intermittent NSAIDs for knee pain or for body aches or for backache, and they will not even consider that they give you the history unless you specifically dig for. So I get patients with abnormal SGOT, SGPT. Of course, we do see a lot of anti-tubercular drugs. We see patients with coming with refractory ascites and cirrhosis because of prolonged methotrexate intake. I think that is another group of patients which we see. And interestingly, these are the patients where even if they are having refractory ascites, you just stop methotrexate, and in 2 to 3 months, they will all start improving. The ascites just disappears, and then they will go on for a very long time. And I think very rarely we have to actually to do transplants for these patients. Most of them would actually recover with just stoppage of methotrexate. ICU setup we have already discussed what causes. Anti-epileptics is another group of drugs which we see very frequently. In one more group of drugs where we do not somehow pick up frequently is Senna. So Senna can cause high SGOT, SGPT, and those who are taking laxatives which contain Senna very often get investigated for abnormal transaminases. So we have to keep in mind that Senna can cause drugs. ART drugs are another group where we see hepatotoxicity very frequently. Amiodarone-induced NASH is also something which we see commonly in our practice. We get references from our cardiology colleagues. Statins, I think, is the other extreme. Yeah. I think statins are over-reported. And very often it is the underlying NASH which is causing the enzymes to be high and not the statins. And unnecessarily the statins get blamed and the statins are stopped. So even in patients with NASH with high enzymes, if there is an indication to give statins, the statins must be continued. So I think that's a bit of a paradox there. Yeah. In fact, there is an oxymoron that if there is a drug which causes hepatotoxicity frequently and consistently, it should not be considered a drug. So I think it's the same philosophy here. So we see the patients who have the hepatotoxicity, therefore we tend to believe that these drugs are very hepatotoxic. But whereas if you look at the community, very small number of these patients will actually be having hepatotoxicity. So what is important is to have a very high index of suspicion for attributing the cause to these drugs when somebody develops hepatotoxicity, rather than actively hunting for mild elevation of transaminases.
Senna alkaloids are also used in homeopathic medicine, so you have to remember that also. Dr. Varghese, you want to add any other common agent?
So whatever the Dr. Akash Shukla is clearly mentioned. Yeah. But usually this I wish to insist, whenever as a clinician we are getting the call over from our colleagues, other departments, once if we go for that, usually we look into that, first of all, that whether not a delay, whether they have associated the liver disease per se, for example, any recent history of alcohol intake, or either we look into the ultrasonogram, because NASH is now more common. So mostly the call over will come to us whenever the mild elevation of the transaminase, that time they will ask, sometimes with even mild elevation of the bilirubin. So mostly we will look into that. Once we ruled out all the intrinsic related, then we will go to that, all the DILI related. Particularly initially the sepsis that I liked it. Actually, mostly the sepsis in ICU, we will get a call, even that they will get confused whether the transaminitis is related to the drug induced or the sepsis or the ischemic hepatitis. So that time the history is very important. Under the patient, once we go, we will ask whether the inotropes patient is already on inotrope or not. That time we look into that SGOT and the SGPT ratio. So if the SGOT ratio is very high, we know that all is ischemic evident. Okay. So the DILI will come into as a last one. Actually, mostly as a clinician, as a hepatologist, we will first of all we wish to rule out whether the patient is intrinsic related to the liver disease. Then only we'll go into the
Dr. Girinath, how big is the problem with paracetamol, and how often you see cumulative or staggered dose of paracetamol leading to hepatotoxicity?
In India, I think we see a lesser case of acetaminophen as overdoses. But according to world statistics, we have two kinds of presentations. One is an acute overdose intentionally. That means they produce a severe toxicity. Around 15 to 25 grams of histamine has to be taken to produce acute hepatic failure in acetaminophen or paracetamol poisoning. So this is one thing. The second thing is cumulative toxicity. That means the patient just takes it unintentionally for some fever, something like that, around 2 to 4 grams per day. Slowly it accumulates, and then depending upon their comorbids, the other parameters, these people can develop acute hepatitis with or without jaundice. So this cumulative and staggering, that is the mostly, maybe in Indian setup, it is mostly the second part we can see sometimes. But till now, for myself, I never seen any case of acute, acetaminophen poisoning overdoses. But I feel the mechanism is that, again, it is the, as we have told, it is cumulative toxicity. The main metabolite is the NAPQ1, that is, and there is gross depletion of glutathione storages. That is the second step. That is the conjugation is lost, and there is a lot of accumulation of this NAPQ1, which damages the mitochondria and produces necrosis. Actually, this induces actually apoptosis, but since there is a lot of ATP depletion in the cell, so we see more of necrosis in these patients, and they present very fast. But the good thing is we have a good drug to combat acetaminophen poisoning. This is my experience. We don't have on-hand experience.
Yeah, we see some cases of acetaminophen poisoning which comes to the ICU, but most of them come within time limits and they do good with N-acetylcysteine. The thing we should remember here is pediatrics are also often present with paracetamol overdose, especially adults. They give the bigger dose of paracetamol, so just be wary of this situation, especially the staggered dose of overdose of paracetamol. So we have already discussed about staggered overdose, which describes the relation of 2 or more supratherapeutic paracetamol dose over time, interval of greater than 8 hours, resulting in a cumulative dose of 4 grams per day. Very interestingly, the FDA approved maximum dose was 4 grams earlier. 2012, FDA suggested but did not mandate a maximum daily dose for adults to be 3 grams, not 4 grams, with no more than 650 milligram every 6 hours as needed. So, especially in ICU and inpatients, we do not try to exceed this 3 gram limit. What happens in ICU or in indoors? A patient is on paracetamol 650 milligram 6 hourly, and as and when patient have fever, 1 gram paracetamol is hanged. So that is also a concern which should be addressed in all the hospital settings.
Yeah, I think it's more to do with the pediatric population.
Yeah.
This is more important because in the pediatric population, the last 5 years, I've seen 1 or 2 cases, similar presentation. But in adults, I don't think I've seen any cases.
My concern remains in the inpatient. See, what we usually do, suppose a patient has pain, we prescribe 650 milligram paracetamol for 6 hourly.
Yeah.
Then whenever the patient has high grade pain or high grade fever, the nurse or the duty doctor, whoever is there, will again hang a 1 gram of paracetamol.
1 gram paracetamol.
That becomes an issue. Since this 1 gram paracetamol is available, people have been exposed to higher doses of paracetamol. We did a survey long back in 2015 at Max Hospital, Saket, and we could find many patients, at least 15% of inpatients were getting more than 3 grams of paracetamol per day. We'll move on to the next topic, Dr. Thomas. What are the overdoses which causes hepatotoxicity in your field? Non-medicinal use, overdoses or poisonings?
Thank you, sir. The past 15 minutes have been extremely educative. My head is spinning, and I really overdo this by saying that ignorance is bliss. I'm glad ignorance is bliss, otherwise I'm terribly confused. But I'll try to get out of my confusion and accept that as far as antituberculous drugs are concerned, it's basically the weight. It is basically weight-based, and I think we need to be very cautious with the fact that it needs to be weight-based, number one. Number two is that what background does this patient come from? Does he have a background of alcoholism? Does he have a background of other drugs like anti-epileptic drugs and things like that? Just like we check for things like, do you have diabetes, do you have hypertension and things like that. I think these sort of hepatotoxic things, I think, are important that you check. So overdose is basically related to the fact that you don't recheck the weight of this patient and probably dose him on a slightly higher dose, number one. The third thing would be this fixed dose combinations that we have today sometimes make the dose a little small or a little too high. Like, for example, if you take a 50 kg man and then you say that if you go by the textbook, you will have to give him 600 milligram of rifampicin, and you will find that least 80% of these 50 kg guys, 45 to 50 kg guys, don't tolerate 600 milligram of rifampicin. You will have to make do with 450, and many times you have found it to be quite adequate. So I think over a period of time, you need to get into this sort of fox paw as such and try and decide your dosing, but please keep the weight in contention. The weight is very, very important, and the weight is in contention. And finally, the minute you suspect anything to do with the liver, I think please stop all your medications. And I think that's the most important. They complain of any GI symptoms over the phone or something. I say just stop your ATT, drop your ATT, and then you come back to me. Now, the question is, suppose they drop your ATT and their liver enzymes and all the bilirubin and all the other stuff come back to normal. Of course, he still has tuberculosis. The bacteria is still multiplying. So what do you do with him? So we try two issues in this situation. One is to use a staggered dose, which is either the real dose or you can reduce the dose. You can dose for about 4 or 5 days to 1 week, and then you add the next dose to that, and the next dose to that, and the next drug to that is such. So over a period of time, patient may be able to detect the real drug, because if you give it as sort of single therapy, like a fixed dose combination, sometimes it becomes difficult to tease out and say which is the real problem. You have rifampicin INH, you don't know what is really causing this, whether it's rifampicin or whether it's INH. So I think that is something that we think. But as far as overdosing is concerned, I think the key here is the status of the liver when you begin and the dose that you're giving, which is related to weight.
Thank you. There are some agents like chemical solvents, paraquat, phosphorus, which is again not a rare intractate for causing liver failure, valproic, heavy metals, which are causing liver toxicity. Dr. Shukla, will be brief. We are already running a little late. What are the drug interactions which contribute and attribute to DILI? Dr. Shukla, are you around?
I'll rather be very quick, and I think we are running short of time.
Yeah.
So I think the first commonest one is we know that in ATT, isoniazid and rifampicin, when put together, they are much more hepatotoxic than individually. So it's 1 + 1 is not 2, but 1 + 1 is much more than 2 in case of rifampicin and isoniazid. The second such situation occurs in patients who are on anticonvulsants. So both carbamazepine and phenytoin increase the toxicity of valproic acid much more. So there again, it's 1 + 1 is much more than 2. We also know that paracetamol can add on to hepatotoxicity of other drugs. Yes. Same way with amoxicillin clavulanic acid. And paradoxically, statins may actually have a protective effect. So that is one situation where, the studies have shown that if the patient is on statins, the adverse events of other drugs are mitigated. So again, NSAIDs are known to have additive effect on hepatotoxicity. And briefly touching upon paracetamol once again, very often we have found patients who are on with acute viral hepatitis during the prodromal phase. They take paracetamol, and that adds on. In pediatric population, the formulation is important. What concentration of paracetamol is there? Very often you write 5 ml, but the concentration is either 125 mg per 5 ml or 500 per mg per 5 ml, and that has led to toxicity. So those are the other things which we have to keep in mind. In alcoholics, 2 grams of paracetamol may be toxic. So that is the third point which we have to keep in mind. So predisposing factors also are important when we talk of drug-drug interactions causing DILI.
So drug-drug, food-drug, and alcohol-drug interactions remain very important. What are the risk factors for DILI, Dr. Varghese?
This based on the number one, I can say the age. Mostly the elderly population, as they already have the associated some of the disease, they are more to get the DILI. And also the obesity, and if they have associated other diseases, if they have the already the existing liver disease, or even the other, because we know not only the bile is the excretor of the drug, sometimes they have associated other organ dysfunction, renal dysfunction, cardiac, and everything will contribute the outcome of the drug delay.
Yeah. How do we assess severity, Dr. Greenath?
Yeah, I'll be very brief because we know that we are running short of time.
We will continue till 6:15, 6:20 if everyone is okay with
Yeah,
it.
it's okay then.
Yeah.
But anyway, I think we know
Yeah,
that
still.
the severity assessment is important. We have a lot of asymptomatic cases and then people come with symptoms. The basic parameters again we take here are the transaminases, alkaline phosphatase, and then the serum bilirubin, INR, and the presence of ascites or encephalopathy, anything is there. So what we do is there are internationally given criteria to know the severity. One is the Dili network criteria for severity, which includes stages of mild, moderate to severe, and very severe or fatal. So first the mild, it means there is the transaminases are elevated, and then the alkaline phosphatase is elevated more than 2 times the upper limit with serum bilirubin less than 1.5. That is mild disease. And the moderate disease is, again, we have an elevation of transaminases and then alkaline phosphatase more than 2 times with serum bilirubin around 1.5 to 2.5. And then again, we have moderate to severe, where associated with these changes, the patient needs hospitalization sometimes. So this is moderate to severe disease. And severe disease means, along with the transaminase more than 5 times the upper limit, alkaline phosphatase more than 2 times, and then bilirubin more than 2.5 with any of the features of encephalopathy or INR more than 2.5, presence of ascites. So this means this is very severe. So, and then we have another criteria coming from the international working group. It is very similar to this. Only just remember that transaminases more than 5 times the upper limit, alkaline phosphatase more than 2 times, and presence of INR more than 1.5 means it is severe. So these are the guys which are going into moderate to severe to acute hepatic failure, and these guys need hospitalization and might need bridge therapies and transplantation. So we take these parameters and see the severity of the disease, to be short.
So for assessment, ultrasound is also not
ultrasound. Actually, the ultrasound, this is just it is not for severity, but we can know. I mean, when the patient has abdominal distension, I mean, the patient is decompensating. I mean, acute decompensating. So that means he is going into acute hepatic failure. So to know the presence of ascites, we remember we need this, and also sometimes this can be a decompensation of a end-stage liver disease. So to rule out end-stage liver disease, the presence also ultrasound is quite helpful. So these are the 2 areas where ultrasound is quite important. But to know the assessment, the causality, it depends on actually sometimes the drugs that are taken into consideration. Sometimes if it is methotrexate, then we might need in early stages, instead of liver biopsy, now we have non-invasive fibroscan and other parameters to assess the amount of fibrosis that methotrexate induces. We have done some studies in methotrexate in our college, I mean in our department, and most of the methotrexate users more than 5 years. The fibroscan was absolutely normal. I mean, it is not showing any severe fibrosis. That means it's quite safe for an Indian population. I still feel that methotrexate is overrated sometimes. So to know the severity, I think still we go by the biochemical parameters, and sometimes we take the imaging modalities.
Thank you. Dr. Shukla, I'll come on to you. What will be the treatment for mild cases?
So I think this is the easiest part. For most of the mild cases, just withdrawing of the drug is usually sufficient, and we really don't need to give any specific therapy. So I think that's usually sufficient. the prevention by giving adequate nutrition is also important for many of these conditions. And so avoid alcohol, good nutrition. I think that is usually sufficient for majority of the cases who have got mild adverse events.
Steroids, we should not be debating for mild cases, or we should be debating it.
So I think steroids should be reserved for those patients who develop drug-induced autoimmune hepatitis.
Okay.
And I think only for that group of our patients who have developed significant jaundice with severe pruritus. So that is the group of patients that is where I would use steroids. I think otherwise routinely for mild DILI, I don't think you need to use steroids. Similarly, these hepatoprotective drugs which are there, they are given more as a placebo effect for those patients who have got mild injury. I don't think they really change the course of the disease for those who have got mild DILI. I think just a stoppage of drug is usually adequate for most mild DILIs.
Dr. Girinath,
Yeah.
what is the outcome in severe disease? How many of them will develop CLD or ALF? I know it depends on the patient factors and on the drugs and the amount of dose.
Yeah. The
And
outcome
can the liver texture also reverse? Suppose a patient develops fibrosis with the drug.
Yeah.
Can that also reverse after stopping the drug?
I'll just take one by one.
Yeah.
Just the outcome, just as Dr. Akash has told, like almost 90%, once we stop the drug, it comes back. Mostly 90% it is good. I mean, if it is in the moderate to severe stage.
Yeah.
And then if we go to the severe stage, that is acute liver failure, they are going into acute liver failure. These are the patients almost 30%, they need 30 to 50% they need some kind of support system or a transplantation. And it again depends on the type of drug that causes this acute liver failure. Suppose it is acetaminophen, fine. You have some therapy. Before we go on for transplantation, you know that you can give NAC. So it depends on the drug also. So, but at least we do have some data showing that it is good that only 30 to 50% need transplantation acute liver failure. When it comes to outcome, usually if there is elevation of liver enzymes and bilirubin in the moderate stage, by end of 1 month, usually they come back and the patient do well, almost 90 to 95%. Only a few percent of patients, they land in chronic liver disease. I mean, what happens is patients are well, only the enzymes, they come back lately. So this is the stage of chronic liver disease, which we say as. And according to international nomenclature, any patient who has persistent elevation of mild enzyme elevation, even after 6 months to 1 year, then only we label as chronic liver injury due to the drugs. And regarding development of cirrhosis, I mean chronic liver disease, this happens in those drugs which produces fibrosis, basically methotrexate, and then in some cases of busulfan, and all these drugs can produce cirrhosis, but the incidence is very less, to say with. I mean, it's not very, maybe less than 1 or 2%. That's all. So they don't usually develop CLD. And prognosis, I told it's good for most of the drugs once we withhold the drug. And whether this can be reversed. Here comes the problem of reversibility of fibrosis. Yes, as Akash has told, definitely a lot of cases due to methotrexate or some other drug. Once we stop the drug, they do well. And even fibroscan studies have shown that there is reversal of fibrosis. It has stopped again, the fibrosis come back. Initially, they were doing liver biopsy. Now, the fibroscan itself is showing the stage that is coming, severe fibrosis, it is coming to lesser stage of fibrosis. Probably, I think the withholding of the drug is very important. And even if they do have early liver disease, end-stage liver, they come back. So there is a reversal of the disease. Unless the patient has 2-3 add-on infections like hepatitis C, hepatitis B, then it becomes a problem. Underlying hepatitis B, hepatitis C, if the patient has this kind of problem, then there can be a progression of the disease and we have to take care of the problem there. So here again, I want to tell again, once we take care of the hepatitis B and C also, now we have seen a lot of studies. There is a reversal of fibrosis even in hepatitis C, even in hepatitis B. Only the problem comes with when there is associated NASH. If it is due to NASH, then the problem is a little difficult because it cannot be stopped sometimes. So we have to find other causes why the liver disease is not coming back. So to my this is the chronology of the outcome of the disease. Thank you.
Thank you. I'll come to Dr. Varghese. What will be the treatment for severe cases like patients developing acute liver failure from drugs?
In Delhi, the severe disease, we can make it as either in one type, it will be a cholestasis. The bilirubin level sometimes will go to more than 10, 50. We have seen sometimes anabolic steroid induced cholestatic patients come with the bilirubin 30 plus. But they will not develop the signs of liver cell failure because the INR, the prothrombin time INR will be normal, and their albumin level due to the nutrition wise there will be the low, but otherwise it won't show very low, and their conscious level also very well. So this is the severe cholestasis due to the delay. Normally that time we will continue the liver supportive medicines. Slowly over the period of time they will improve. Second is sometimes this cholestatic patient slowly they develop the ascites and mild coagulopathy. It's called subacute liver cell failure. So the delay patient, even we have stopped the cause of the drug and we are giving supportive care, but over the period of sometimes 1 month and beyond 1 month time, slowly they will develop the subacute hepatic failure. The subacute hepatic failure, once we diagnosed, definitely the particular patient require liver transplant. The other end is the acute liver failure due to delay, the paracetamol poison.
Yeah.
And this even we have not done even a single transplant, even though we have enough experience, but the paracetamol induced acute liver cell failure, because this is rare in our country. So in Western population, the most common indication for ALF comes the paracetamol, but in our country it is not like that. Once the acute liver cell failure means there is a coagulopathy and encephalopathy, and by ruling it out, all other causes, and finally the ALF. So that time also need the transplant. So meantime, either it is the cholestatic phase, or in acute liver failure, or in subacute liver failure. That time, there are the options. So now in various institutes, we are adopting the plasma therapy. So yeah, this all somehow will help to the patient. With severe cholestatic disease alone means the plasma therapy, the consequent plasma therapy, it shows the good outcome. In the acute liver failure due to delay or subacute, this will help to prepare to make the patient ready for transplant, donor evaluation, or waiting period for the cadaver organ. That time it will help. So once they reach the either acute liver failure or subacute liver failure, the treatment protocol for the particular individual has to stick on for that scenario, what is the protocol is there? The same ICU protocol, we have to follow it up.
Yeah. Dr. Shukla, are you around?
Yeah.
What is the role of NAC in paracetamol and non-paracetamol DLI?
So I think it is the first line drug and curative for a lot of patients of paracetamol poisoning. We use it routinely at 150, 50 and 100 mg per kg. That's the dose for first 30 minutes, 4 hours, and then over next 24 hours. For paracetamol poisoning, it is routinely recommended for all acute liver failures based on the US multicentric study, where irrespective of etiology, it was found. So I think as a dictum for all patients with acute liver failure, unless there's a contraindications, all patients should be given IV N-acetylcysteine. Of course, for non-paracetamol, the dose is 150 mg per kg over 24 hours for 5 days. But of course, this also varies from one institute to another institute. But usually it's a high dose IV N-acetylcysteine which needs to be given, not the 600 mg BD dose that we give for prevention of contrast-induced nephropathy. So I think as a dictum, we should use it for all patients who develop acute liver failure due to DILI or paracetamol DILI or any other ALF.
Dr. Varghese and Dr. Girinath will agree on this point?
Yeah, fully agree. Because
Okay.
the N-acetylcysteines play a vital role. Because
All
earlier,
drug-induced liver failure you will like.
exactly.
Dr. Thomas and probably all of you, what is the role of glutathione?
Before this, can I just have a question?
Yes, sir.
I don't think I'd ever get 3 gastroenterologists together. So let me ask them this question. There is this routine habit of prescribing the so-called liver support, as Dr. Joy rightly said. I just want to know what is liver support and what is the role of liver support in a normal person, normal weight, no comorbidities, no metabolics. I prescribe anti-tuberculous drugs. Sometimes I ask myself, is it really necessary to give this guy the Silimarin and the Phylanthus neruri and Eclipta alba and all those things? Today, people have started asking for that. Why only TB drugs? Where are my other drugs? What is my liver drug? No, that's the way they've started asking us. And I have started questioning myself. Is it really necessary to give these drugs to all people across the board, or you be selective in whom you give?
So I'll answer that question for you, Dr. Thomas, first, because before any controversy starts. And fortunately, this is an audience question as well. And the audience has also asked exactly the same question.
Exactly.
If hepatoprotective drugs work, then why not give everybody right from the beginning along with anti-tubercular drug? I don't think and there is any evidence that we are going to benefit a large number of people by giving. I don't think it is indicated at all.
Yeah, that's my take also. Yes.
So I think you are perfectly right. And if you are in minority, I am in minority too, probably.
Thank you.
Dr.
Thank you for taking sides.
What is the role of glutathione in DILI?
I don't think, as far as anti-tuberculous drugs is concerned, glutathione by itself may be one of the postulates and deficiency which can cause this sort of thing. But the point really is that as a pulmonologist, I'd be least interested in glutathione as such, because I would rather be interested in other things like I told you, the sort of liver support and things like that. Now, those are my daily bread and butter entities that I have. Daily people asking me about this, and I think that's really what this is about. I really do not have too much of knowledge about glutathione at all, to be honest with you.
Dr. Varghese, your take?
So this what we are giving the N-acetylcysteine. N-acetylcysteine is indirectly increasing the glutathione. So it is an antioxidant, the glutathione basically. So any liver injury, either drug-induced or ischemic-related liver injury, or even toxic, the direct toxicity related. So it's all at the time the free radical release, oxygen free radicals that related injury somehow, either the N-acetylcysteine or directly if you are going to give nowadays the glutathione is available in the market. So these all, but there is no RCT trial. So I don't know, as far as my knowledge, I have not seen. So, but N-acetylcysteine increasing the glutathione level, that has been well documented, and it acts as an antioxidant. Same way, the glutathione by giving directly also will help to reduce the ongoing inflammation process.
So it has some physiological basis, and drug-induced liver injury leads to depletion of hepatocyte glutathione, but it exerts its effect at least partially by mechanisms that are independent of increasing hepatic glutathione, but probably act through cytokine-mediated and anti-inflammatory mechanisms also. There have been some reports in usage of glutathione for thiol compounds-induced drug-induced liver injury, and for some poisonings like sulfur mustard poisoning-induced liver injury. Dr. Girinath, I'll come to you on this question. What is the role of other ancillary therapies, as Dr. Thomas already pointed out?
Other ancillary therapies apart from NAC, which is very specific, used in all the acute liver failure. The role of ursodeoxycholic acid, it has some effect in cholestatic type of delay, but there is no supporting evidence. Definitely, there are no RCTs which promote the use of ursodeoxycholic acid unless there is a pure cholestatic syndrome. And regarding carnitine, especially, this has been used quite a bit in valproate-induced injury, and it has shown good results. And regarding the natural products like silymarin or curcumin or ginkgo, I don't think there is any role right now because we don't have any control studies on these drugs. There were some studies with silymarin and some of the drugs, but till now curcumin, I think it's still under trials in one of the centers. But I don't think for a physician perspective, there is no role for these kind of natural products right now. Maybe in the next 5 years, curcumin can be a role sometimes in some particular drug-induced liver disease. I think apart from NAC and carnitine, which has specific uses, other products doesn't have much role in therapies.
I'll come to Dr. Shukla now. Can the inciting drug be restarted?
Sorry, I didn't get your
The
question.
inciting agent which caused delay, can it be restarted?
So yes, in many places we are able to restart, especially in antitubercular drugs. We can re-challenge. Of course, the way and the sequence varies according to individual people. Where some people would want to start off with half the dose and then go. Some people will start rifampicin first. Some people will start INH first. So it varies from one protocol to another. For those conditions where there is chronic injury, like methotrexate induced liver fibrosis or anti-epileptic induced liver fibrosis, in those conditions, re-challenge is not recommended. So for acute hepatitis with antitubercular drugs, yes, re-challenge is okay. Probably with NSAIDs, yes, re-challenge is okay as and when required. But anybody who has developed a severe toxicity, re-challenge is not advisable. For those patients who have developed chronic injury, re-challenge is not advisable.
And obviously, it must be done after proper risk stratification.
Oh yes, it should be done only after the liver function has become completely normal.
Yeah. Dr. Girinath, how can we prevent delay? This is rather a subjective and philosophical question, to be very honest.
Yeah. Probably prevention means maybe, at the prescription level, it has to be very apt. Like we have to see the comorbidities of the patient when we prescribe drugs, and then what are the other drugs he's taking, what are the other diseases he's having. So first we have to concentrate on the comorbid condition, the age of the patient, the gender, again, as these are all the risk factors. So we assess the risk factors. So when we prescribe the drugs. And the second thing is we take the help of a clinical pharmacist. It's good if you have a clinical pharmacist. And definitely we always tell the patient, if you have any problem like nausea or vomitings, immediately after you take the tablet, it can be anything. If the patient has any symptoms of hepatitis, within a week, please come to us. So this is very important because they think it's due to other causes. Again, they go to some other doctor, so they cannot sometimes identify the problem. They go on other drugs for vomiting. So this continues sometimes. So this is very important. We have to educate the patient while we prescribe any drug, because almost all the drugs have some percentage of hepatotoxicity. It can be idiosyncratic. So we have to be very careful in advising the patient. And the second thing is the lower number of drugs in the prescription is always good. Don't go for a huge number of list of drugs. And also we have to get ourselves acquainted with the newer drugs and the newer hepatotoxicity for us. So this is very important. The second thing is what I want to say is, suppose the patient already has some amount of mild elevation, that is mild hepatitis. So this is the stage where we want to prevent them going to the next stage. So we have to monitor them. So these are the patients we want to monitor every week. If they have any mild elevations and they go on increasing after 2 weeks and they go into the moderate stage, then we have to be very careful and stop the drug. So these are the precautions we take and tell the patients. The second thing is, on a population level basis, always tell the patient that please don't take any herbal medications. This is very important. and unknowingly they take a lot of medications and the dietary supplementations, because we see a lot of anabolic steroids and some similar drugs being used for bodybuilding and muscle building things. So we have to advise them also. So this is how we can actually prevent, to some extent, drug induced as well as herbal induced and dietary supplement induced disease.
Most of us are using e-prescriptions for OPD and IPD, and the software, whatever we are using, they prompt us. We often overwrite it. If we are using more than one nephrotoxic agent, more than one hepatotoxic, they give us a prompt, but we often overwrite it. So we should be hearing to those prompts and do a smart prescription
Yeah, that's
and use
very
artificial intelligence as and where possible. What is the role of multidisciplinary team in prevention delay, especially in hospital setups?
The treatment part, the multidisciplinary team will play a major role. Treatment, but the severity of the liver disease, once they go to the acute failure, that time the intensivist and the transplant surgeon and hepatologist, that is the team play. The prevention part means only they can educate the clinical pharmacist, because we need, the institute need the better the clinical pharmacist, and we have to interact, because that people usually the drug to drug interaction related, they will pick up early and they will guide us under the physician assistants, because each day nowadays the consultants have either the physician assistants or the duty doctor. When this, even though consultant visit, even after the order, they have to be verified, because even this, the spelling mistake, sometimes it will lead to the totally one drug to other drug change and the toxicity. This all has to be very carefully we can manage.
So, Dr. Thomas, do you use smart prescriptions, e-prescriptions to make your practice safe?
I think the best thing would be to use common sense here.
Yeah.
The common sense
Absolutely.
will mean that you look at the weight, look at the dose, look at the pre-existing condition, anticipate side effects of drugs, and I think that's about all. It's a simple common sense side of thing, and I think we need to communicate to patients and tell them, if you do get these symptoms, please come back to me. And I told you about these 10 days that I generally start off with. And 90% of my problems are over in those 10 days itself. So it makes my job very much easier. So all of us have to work out, at least I would prefer that I work out something like that, which is tangible, which is feasible, which I understand, which my patients understand as well.
Very wisely told. And we should not lose the art of medicine in this all
Exactly.
jugglery of medicine. The practice points from the discussion are: the number of cases of delay is expected to rise because of increased availability of prescription medications and burgeoning of this dietary supplements. Pharmacist and multidisciplinary approach should be followed. It is essential to perform a thorough medication history whenever we suspect delay. Once delay is confirmed, it should be referred to a gastroenterologist. I'll make it simple. And medication therapy management is one tool pharmacists can use to identify patients who have delay or at risk of delay. We'll take the questions from the audience now. Yeah.
I think they are already there in the chat, Dr. Yash.
Yes.
You can read from there.
From the beginning. Audience question. The risk of ATT-induced hepatitis in HBV carriers. The risk of ATT-induced hepatitis in HBV carriers. Any of gastroenterologists?
So I think there's a very good Japanese study which has looked at over 80,000 people with hepatitis B asymptomatic carriers, and they have found that the risk in those who are true asymptomatic carriers is the same as those as the general population. So it's not different. But the key here is the true asymptomatic carriers, not the ones who have developed fibrosis and the LFT is still normal.
Next question is from Dr. This question was from Dr. Hari Prasad Yadav. The next question is from Dr. Gaurav. Recently, I am coming across a lot of doctors advocating fibroscans in people with short duration or unknown duration, but recently detected elevated hepatic enzymes who have a history of using alternative medicines. Is it useful? Any of the gastroenterologists can take this question.
So again, I'll take this question. Just actually, we are in the process of writing the paper. I don't see a use of fibroscan for somebody who is on short-term drugs and the enzymes are very high. In fact, you will falsely report a high value and you will overestimate the fibrosis because the liver is stiff because of the inflammation of the liver rather than because of fibrosis. So actually, this is an inappropriate use of fibroscan. Fibroscan should be done in somebody who has had a stable enzymes for a long period of time. They may be high, but they have to be stable for some period of time. And people to assess chronic liver disease, not with anybody with acute insult, not anybody with acute hepatitis or a flare of hepatitis. Invariably, you will overestimate the value of liver stiffness.
The next question is from Dr. Alvin. When to consider liver biopsy and role of plaques in severe DILI? What is plaques?
Plasma exchange.
Yeah, can I take the question?
Yes, please.
Yeah, Girnath here.
Yeah.
In Delhi, we do liver biopsy only when we doubt drug-induced, immunohepatitis. That's very important. Or the patient's enzymes are not returning even after 6 months and the patient is going to some kind of chronic liver disease. We need to establish the diagnosis. So these are the two main things where we need a liver biopsy sometimes. Otherwise, in acute hepatitis due to DILI, there is no role of any liver biopsy right now.
Role of plex, I'll suggest. So I think the one place where we have found it to be very useful, that is plasma exchange, that is plasmapheresis and plasma exchange, is in patients with retol poisoning. I think that is one place where plasma exchange we now know works very well, and now we are in fact able to save most of the patients with retol poisoning without liver transplant because of availability of, because now we know how to use plasma exchange in time. So I think that's one place where it is useful. For all other acute liver failure with a lot of SIRS without any sepsis, I think is right now the indication. But I don't think we really know exactly which group of patients will benefit and which will not. Yes, where in conditions where you can remove the active form of the drug through plasma exchange, there may be some role. But again, in clinical practice, I've rarely seen such a situation because by the time the patients develop liver failure, the levels of the drug in the plasma have actually invariably gone down. So I don't see routine clinical use, although theoretically it may sound very appealing.
Here I wish to add one more point regarding the plasma exchange. The plasma exchange we have done only for the severe cholestasis due to the DILI. Some of the patient will come with the bilirubin level is, as I told, more than 20. So that time, along with the liver supportive medicine, so by doing the plasma exchange, we can bring down the bilirubin level close to 10. But in practice, because we have done more than 1,500 plasma exchange in the last 8 years for the various liver disease, so we have already submitted our article for the cholestasis, the DILI-induced cholestasis, the plasma exchange role. It's showing a very good outcome, but exactly the mechanism we don't know. Just it is bringing down, it is stabilizing the value, and we have done a lot of the cytokine analysis and everything. We are waiting for the reports.
This question is from Dr. Ramurthy Singhal. Comment on fluothane induced hepatitis. This volatile agents, anesthesia. Again, there's causes idiosyncratic, but the reactions and the drug-induced liver injury has decreased quite a bit with newer volatile agents as of now. Anyone wants to answer that further? Halothane and volatile agents.
I think it's becoming increasingly rare now.
Yeah.
Because this is hardly ever used. I don't seeing a single patient recently.
There is another question from Dr. Regia Sultana. In case of anti-tubercular drug-induced liver injury, what is the next step of management? When to start ATT again? And what interval LFT should be checked?
Akash, you have told now.
Yeah, this we have already taken. What percentage of acetaminophen related ALF recover only with NAC and who doesn't need transplant? This is a good question.
So I don't. So I think the literature-wise, I think now we know that the hyperacutes, because of paracetamol, in fact, a majority of them would recover without transplant with increased care. And I agree with Dr. Joy Varghese with the increased use of plasma exchange for this group of patients. Also, I think there is a huge change in the outcome. So good management, I think timely management. CRRT and plasma exchange has changed the outcomes in patients with paracetamol poisoning. I don't have a large experience. We have had only 3 patients in the last 3 years, and I think all of them recovered. But that's why the NHS have also amended the criteria for transplanting patients with paracetamol poisoning. And I think persistent lactic acidosis now is one of the key features for indication for transplant now.
The last comments from anyone who would like to summarize the discussion. Dr. Varghese, will you like to summarize the discussion?
Delhi in our country, I can say it is underestimated, because whenever the symptom comes, most of the patients are getting referral from the other consultant, or sometimes the patient themselves they are coming. So the Delhi, the definition wise, there is a transaminitis. So already we discussed. So mostly, if whatever the evidence at present in India, it is underestimated. Second thing, we have to know what are the common drugs will cause the liver injury. So already we discussed. So the common drugs, the anti-tuberculous drugs, anti-epileptic drugs. So these are the common drugs it will cause. And we have to know who are all the risk factors, in which group the DILI will behave very severe form. That also we all discussed. The age plays a major role, particularly elderly group, the DILI severity will go high. Second thing, if they have the female comparatively with the male, they will get more. And the associated comorbidity disease like diabetes, obesity, etc. So that group we have to be, so we have to know the risk factors, and we have to assess the severity, and we have to stop the drug. First of all, whenever we have a suspicious, we have to withhold that drug into that particular drug. Then we have to add the liver supportive medicine. Then we have to see mostly more than 90% of the individual, whatever the cause of the DILI, usually they will recover very well without any sequelae. But some subgroup, they will go to the either the severe cholestasis form, or sometimes acute liver failure, or sometimes subacute hepatic failure. That groups, so we have to go for the recently available the plasma exchange, and ultimately the failed groups, they might require for the liver transplantation.
Thank you. At the end, I'd like to thank all the panelists, Dr. Grina, Dr. Thomas, Dr. Varghese, Dr. Shukla. It was a very, very lucid discussion. And I request all of you to stay safe. And thank you for joining us. Thank you.
Thank you.
Thank you very much,
audience.
Dr.
Thank you very much for that.
And all the co-panelists. Thank you very much.
Thank you to everybody. God bless. Stay
Bye-bye.
safe.